This is the Medicast, April 4th, 2011.
Transmitters? We don't need no stinking transmitters.
This is the Medicast, a podcast for EMS providers by EMS providers, featuring EMS news, products, tips, tricks, and commentary. So grab your gear and glove up. Here's today's show with the pod medic, Jamie Davis.
Well, good day and welcome to this week's episode of the Medicast. I'm your host, Jamie Davis, the pod medic, and I'd like to welcome everybody to the program this week. And we are back in the studio after being down at EMS Today 2011 at the beginning of March. And so the last several weeks have been featuring episodes recorded live at EMS Today 2011 in the podcast studio there. And we want to all, from the ProMed Network, all of us collectively thank GEMS.com and, of course, EMS Today, the conference organizers, and everyone for inviting us and having us there and allowing us to cover the event so that you could see a little bit about what's going on at EMS Today if you weren't able to make it. Of course, we did get a chance to meet a lot of listeners and viewers of the show, and I just wanted to say thanks a lot for coming by the booth and making sure you caught up with me. I know I was in and out quite a bit, so if you came by trying to catch up with me and I wasn't there, I apologize. But we had a good time, and a lot of you even came out to some of our after meetup parties where we actually did a karaoke one night. Just kind of spontaneously tweeted out to everybody that we were going to do karaoke in a nearby establishment, shall we say, and we had a lot of fun with that. So I do want to thank everybody. We're going to get into the rest of the show here pretty quickly, but I do want to remind you to find links to everything we talk about and a lot more information, articles, and contact info all over at mediccast.com/blog. That's right, mediccast.com/blog. Check it out, and I'll be back here in a second with listener mail. Time to jump in and check out this week's listener email, and I've got a lot of emails that came in and I've tried to answer everybody back, so I hope that I did so. I picked a couple of them to read here on the show just to kind of bring them up to you, a couple of things that came up. I got one email in from a listener talking about non-traditional EMS providers, and he sent it from his BlackBerry and didn't sign it, so I don't know what the individual's name is. It could be a she, actually, but it talking about the Department of Homeland Security that has EMS providers in their ranks that might be Border Patrol agents or other members of the response organizations that are part of the Department of Homeland Security. And so there are lots of other people out there, and we could do a whole show on that, but the standards for their practice levels are probably very similar to everyone else's. I mean, they are EMTs or perhaps EMTIs or paramedics. And so there's not a whole lot of difference from that standpoint. We've had some talks with people about tactical EMS, which is what I think these individuals would be more likely to face. But aside from that kind of a specific type of trauma call, these individuals are still EMS professionals. Whether or not they use it on a regular basis in their jobs, it's something that they have to carry as a requirement for their other training. And I think it's a good thing. You know, you need to have some basic EMS and first aid skills if you're in any kind of emergency response job or task, because there are going to be situations where you're going to need to provide on the scene emergency care right at the scene of an emergency. And until the EMS units get there, you are going to be the provider on scene. And so that's something to keep in mind. But I do thank you for your email. Make sure you put your name, at least your first name, in there so I can know how to respond back to you. And I do appreciate you sending it in. It's great to get emails. If you take the time to send me one from your mobile device or whatever, I just love hearing from each and every one of you. So thanks a lot for that. I also got an email in from listener Daniel, who had an idea for a show. He has another podcast he likes to listen to called the ER Cast. There are lots of great podcasts out there, folks. I mean, I listen to a bunch. You know some of the ones I listen to quite frequently. A lot of them are members over at the ProMed Network, so you can check out all of the healthcare-related shows. I mean, there are programs over there that are aimed at people from physicians all the way down to emergency medical services providers like us. And there are things in each of those shows that can be used for each of us. But he did want me to check out the ERcast. He gives me the address is ercast.org. Check it out. I've heard good things about it. I actually haven't listened to this one, but there are a couple of others that I like to listen to that are outside of the EMS realm. I like to listen to Jeff Guy's, what's it called? ICU Rounds podcast, which is really a great opportunity to get some in-depth looks at some specific medical conditions from the aspect of a teaching physician in a medical school who basically is talking to residents and med students about specific issues regarding infection, CHF, pulmonary edema, whatever the case may be. And he goes into some of the in-depth details, so some of it might be over your head, but it still makes a lot of sense, especially for those of us that are, in advanced care providers in the EMS sector. We're thinking about things like, some of those upper level thoughts about critical thinking, about what we're going to do. And some of the things that he talks to us about really makes a difference. And so I enjoy that podcast quite a bit. There's a bunch of other shows. That particular one isn't on the ProMed Network, but it's just an example of just a lot of great stuff out there. Daniel, thanks a lot. I'm actually going to get in touch with these guys. Maybe we can get them added to the ProMed Network, and also see if we can maybe have them on to talk about being medical director. And I've got some contacts. I actually made an EMS Today recently as well on some ideas for docs to bring on the show and talk about medical direction. We've done that in the past with Ginger Campbell, who is the host of the Brain Science podcast. She's an ER physician, and she came on to talk a little bit about being a medical director and dealing with medical direction, and so something to keep in mind. I also got, finally here, an email, probably a long email from listener Becca, and I say long not because I'm upset that it's long, but there's quite a story that she tells, but it's also not a story that is unfamiliar to me or unfamiliar to a lot of you, I suspect. She works for a transport company. It's an interfacility transport company that goes between hospitals, between nursing homes and hospitals. We all know there are lots of services out there that provide that. They do run some calls that she considers emergency type calls, but she was concerned because the nursing home facilities call these medical transport companies to take a patient to the hospital in situations that might be considered an emergency. And that her unit runs lights and sirens over quite a distance, 20 to 30 minutes, to get to a place to transport a patient that should have been maybe taken by a 911 service. And it was concerning to her. And she kind of, finally, I just kind of get into the questions that she asks me because I think they're important to keep in mind as I drop the papers everywhere. She had some concerns, but she was told basically that if they didn't take the transport for some of these calls that might be considered emergency calls, that another transport company would be used. And that she didn't also feel that there was a whole lot of contact with her medical director. So just some comments on this, Becca. First of all, I completely sympathize. It's very difficult to be in a situation like that. And on the other side of the coin, there are EMS services and 911 services out there that complain about the local nursing home calling 911 for a patient that's non-emergent, just because they don't have an available ambulance for 3 or 4 hours to take them to the hospital for a potential sick problem and not necessarily an emergent problem. And so they call 911. And so there's issues on both sides of this coin. And it really is about effective and appropriate use of the system. So that's one thing, but that's something that's really probably above your pay grade at where you are. How can you deal with doing these types of transports and focusing on what needs to be done and how your bosses and your medical director responds to these things? I would say this: treat every single patient as an individual call, an individual patient, and don't sweat the other stuff. And I know that maybe is easier said than done, but it is something to just keep in mind. If you're the person that's been given the opportunity to come in for the call, take the call. It's your job. And if it was inappropriately directed, well, you can just make an appropriate suggestive comment to say, you know, if the patient's in distress, don't forget that there's 911, but we're happy to take your patient. I mean, part of your job as an employee for a company is to represent the company appropriately and professionally. So you never want to make a snide comment, but you could potentially say, you know, just keep in mind that 911 is an option for patients. Even if they are a DNR, there are things that can be done for that patient en route to the hospital to keep them comfortable while they are being transported. So that's one thing. The other side of it is just treat the patient and take the opportunity to learn and practice your skills and do the best job you can, because your boss is right. This is the way that system works, and it works this way in many different parts of the country. And if you aren't the paramedic in the unit taking the call, another company's paramedic in the unit is taking the call. So be aware that this is something that's not uncommon, and take the opportunity to treat every patient as an individual, and don't worry about the management decisions that go on behind why you're the one that's doing that. Just do the best you can. Make sure you document carefully and try to learn something from every single patient about how to treat their problem, about what's going on with them, about practicing your assessment skills so that you are better and better and better each and every time. You know, I think a lot of 911 services out there kind of scoff at the transport companies. And I would say that the transport companies are really a very good training ground for a person to become an excellent critical care paramedic. Because you can run 911 calls and get all the motor vehicle accidents in the world, but you become an excellent patient assessor by routinely transporting patients with a variety of medical conditions. You get to recognize things very quickly. You get to see a lot of different medications and diagnoses. You interact with other medical professionals than just the ER, and you have an opportunity to really excel in the field in your chosen profession of EMS. So I hope that that helps you, Becca, and I thank you for listening to the show. I know you said I'm busy and it took me a while to get back in touch with you. That's true, I am busy, but I'm never too busy to try to answer these kinds of questions and at least respond back to each and every one of you when you send an email in. Send those emails in to podmedic@mac.com. Almost forgot which show I was doing there for a minute because I was going to say the nursing show email address. But anyway, you can send those emails into podmedic@mac.com, and you can also, of course, leave a comment over on the website. When you leave a comment there, it sends me an email that a new comment's been posted, and it also will, you can of course call into the voicemail line, 941-306-3342, 941-30-MEDIC, and leave a message on the voicemail line for me. So there are lots of different ways to catch up, and I look forward to hearing from each and every one of you real soon. Time to jump into this week's news, and we'll start off with a news item I picked up out of a local paper, delmarvanow.com, a local agency, actually a couple counties away in Delaware, took top honors at the GEMS Games competition at EMS Today 2011. And I don't know if you're familiar with what the GEMS Games are or the concept that this kind of competition brings around, but basically you put together a team of providers from your region and you practice doing different types of assessment, different types of calls. It could be trauma, it could be hazmat, it could be medical related, it could be any kind of things. And you have to come in and show off your skills. It's a great opportunity to learn. When you do this kind of intensive training and work with groups of people at different levels of provider excellence, you get to become a better medic yourself or better EMT yourself, and you also get to go and show off your skills and promote your service in your region, your state, whatever, at this competition and others like it. So I would urge you to consider signing up for something like the GEMS Games next year. Sussex has taken this award before. Sussex County, Delaware paramedics brought home the top award this year, and they did so as well in 2005. They've won silver medals in 2006, 2009, and 2010. And in 2008, they went to the international competition for EMS games and won third place at the competition in Israel. So really very cool. And there are lots of opportunities to just go so far and see so many different things, work with different services that have a different structured response model than you do. Work with services that are hospital-based versus fire-based versus third service versus private company. There are police-based EMS agencies out there. You could be a border patrol group and put together a group that comes in and works at the GEMS games. You know, there are lots of different things that you can do, and I would like to see a lot more teams coming and competing. I think there were 16 teams this year, but this could be a huge event and a big competition that could maybe spring out to be regional offshoots, and then everybody comes together for a national competition. There's just lots of neat things that go on here. If you haven't ever participated in that kind of competition, I would urge you to do so. And check out the information about the GEMS games over at emstoday.com, and you might decide that next year it's going to be your turn to check out your skills at the GEMS games. Next up, we have two different articles in the news about cardiac issues and some things that are on the horizon and changes that are being considered regarding specific types of cardiac history taking and cardiac prevention, cardiac event prevention. Heart specialists got together recently to try to come up with a consensus to reduce sudden cardiac arrest deaths in young athletes. So we're talking teens, college-age students who appear to be otherwise very healthy. They're competitive athletes, but they may have a hidden cardiac condition that crops up and causes them to spontaneously go into cardiac arrest. Now, we know that there are more and more AEDs in schools all around the country, and this is because for those cardiac arrests that are stimulated by a blow to the chest at just the right moment in the QRS complex, or just after the QRS complex, that is something that could save someone's life very easily, and we see those kinds of stories all the time. This is talking about patients with a hidden congenital heart defect or a hidden cardiac condition that may have been going on their entire lives. Maybe they caught a virus when they were young. It was the common cold, but for some reason it transferred and settled into the heart and caused the thickening of the heart muscle. And so over time, that heart muscle became more and more, or less and less able to beat effectively. The thickened heart muscle doesn't transmit energy as efficiently. And so a situation occurs where the heart is under stress and it goes into cardiac arrest. And in this situation, it may not be a shockable rhythm. So it's something that there needs to be done. One of the things that you can do in your community is check in with your local sports athletic system, whether it's your local high school, your local board of education, local colleges and universities if they're in your run district, and ask them how they are assessing patients, assessing their athletes for hidden cardiac conditions. This particular article points out that the American Heart Association recommends 12 different history-taking questions that can be asked to determine if a patient needs follow-up studies to see if there's something going on. So this is something that actually makes a lot of sense. There may be a patient history of a cardiac event in their family. Uncle Joe, Uncle Joe died suddenly at the age of 25. He was running with some friends and just fell over dead. Well, if we know that Uncle Joe died at a young age, maybe there's a hidden family genetic history for some kind of predisposed cardiac condition. And so that's something to keep in mind. And as people on the forefront, as the people that are going to be responding to these sudden cardiac arrest situations, it makes sense for us to be involved in the preventative process as well, and to encourage our local athletic organizations to be aware that this article is out there, that there are guidelines put out by the American Heart Association that can be easily printed out and given to a family or given to a student to go and take when they get their physical done, so that it can be all taken care of and monitored by the physician. The physician can ask these questions and then determine if there's a need for follow-up, and all that information is included. So it makes a lot of sense. Something to keep in mind, nobody wants to go to a situation where a young athlete is died suddenly and is not being resuscitated effectively, and it just destroys the whole community. And we saw things like this happen in our community a few years back, and an otherwise perfectly healthy, top-level state champion athlete falls over dead from an aortic aneurysm. Clearly, there must have been some problem with his aorta that was causing him to be at increased risk. This isn't something that just happens to a healthy individual at a young age. So obviously there was something going on there. Again, could a history have a careful history focused on cardiac events in the family history done something to alleviate this? Well, heck, maybe an ultrasound could have been done based on some markers in the family history that might have pointed out that, hey, look, there's an aneurysm here. And that aneurysm breaks, this person's going to die, because AAAs, that's what happens, right? So let's think about what's going on in these situations and make sure we educate. Don't assume that your athletic directors are aware that these screening tools are out there and that they can be included in the packet for the physicians to fill out, just like any other piece of paperwork that they fill out for standard physicals. Finally, a lot of you may have seen this article. Did anyone see the article with the big headline that says sex can boost your heart attack risk? Slightly. Everywhere I've seen this, it's actually, the slightly is on the next line. So that all you see is sex can boost heart attack risk, right? Well, yeah, it can. And apparently the study was done that showed that there is an increased risk for heart attack after any series of strenuous events. And that this lasts only for a short time frame, 1 or 2 hours, but it is there and it is present. Does this mean we shouldn't exercise or, God forbid, not have sex? Well, okay, first of all, if you're not old enough to have sex or you are not in a position to do so, I didn't tell you to do that. But anyway, you do need to keep in mind that there is something to be said for making sure that we understand some of the recent history that can lead to a cardiac event to occur. And that's why I bring this article up. One of the things that I am always saying, and those of you who have been listening to the show for the last 5 or 6 years have heard me say it again, time and again, be very good and careful about taking your medical history. Be proactive about it and increase your knowledge about what types of questions you need to be asking. This is a perfect example. When you ask the question about events leading up to the, things that were leading up to the event, when you're going through your sample history, right? What kind of questions can you ask about something like this? Were you doing anything, was the patient doing anything strenuous prior to the event? Maybe you've got a patient that you're not sure if it's an MI or not. Maybe they've got some hidden symptoms. Female patients, this happens all the time. So imagine if you know about this article and you can ask a few questions. Hey, have you been exercising recently? Or did you have any strenuous activity recently or sexual activity recently? And when they say, well, yeah, an hour and a half ago I was raking leaves in the backyard. Well, just because they didn't immediately fall over in the yard doesn't mean that their risk for heart attack isn't slightly increased following that time frame. So by asking that question, it just gives you another not definitive marker, but certainly something that can point you in the direction of what's going on. Now, if that was 3 hours ago, no, this article clearly states it's 1 to 2 hours after the event. So that's a short time frame, but it does give you the types of questions that you need to ask in these situations. And I would urge you to read articles like this. Dig into websites like webmd.com periodically and just read what kind of research is out there and what some of the studies are finding about cardiac events. There's just lots of information out there that you can pay attention to. Let's go ahead and close out the news segment. I do want to remind you to go ahead and check out the links in the show notes for all 3 of these articles. And if you have any questions, you can go ahead and reach me by email, podmedic@mac.com, or you can go ahead and leave a comment on the show notes for this episode over at mediccast.com/blog. Time now for this week's tip of the week, and this week's tip of the week is another segment with Lisa Booz from the Maryland Poison Center. Lisa came on to talk about caffeine. So we're going to be talking about caffeine overdoses, the caffeine drinks, different ways that people are ingesting caffeine to stay awake, combination caffeine and alcohols, drinks, things like that. And this has been a question that's cropped up periodically from listeners and viewers of the show. So I wanted to go ahead and get this segment out there to you. This is Lisa Booth from the Maryland Poison Center. And let's go ahead and jump into that phone recording that was made about a month or so ago and talk with Lisa about caffeine overdose. And I'm back with another segment here with Lisa Booth from the Maryland Poison Center, back to talk to us about our toxicology updates. Hi, Lisa.
Hi, Jamie.
What do we have today?
Well, Jamie, I bet you're like most Americans in that you like to drink coffee, tea, or cola sodas, right?
Yeah, I do.
I figure that most people do, and in some cases, maybe for most of us, the caffeine content's the main reason for drinking them. Of course, we all know in moderation caffeine's safe, but most people don't realize that caffeine can be quite toxic in large doses. Now, caffeine is a central nervous system stimulant. It produces alertness, restlessness, hyperactivity, but it's also a cardiovascular stimulant, so it increases the heart rate and it can increase the blood pressure. And when people drink large amounts of caffeine-containing beverages or products that contain caffeine, one of the first things that we see is a lot of nausea and vomiting. It can be very severe. It can be very protracted. Caffeine's also a diuretic, so consuming very large amounts can also lead to dehydration. And with real large doses, more serious effects can occur. So we sometimes see dysrhythmias like supraventricular tachycardia, atrial fibrillation, and VTAC, ventricular tachycardia. Can also see seizures, metabolic acidosis, low potassium levels, and ultimately cardiovascular collapse. The dose that we see these serious effects is fairly high. It's about 1,000 milligrams in an adult, or about 40 milligrams per kilogram in a small child. The lethal dose of caffeine is estimated to be somewhere around 150 to 200 milligrams per kilogram in an adult. So to put those doses into perspective, here's the caffeine content of some foods and drinks and medications that we see around our homes pretty much every day. The amount of caffeine in a brewed or instant cup of coffee can be anywhere between about 50 and 180 milligrams. Tea contains 20 to 90 milligrams per 5-ounce cup, and a 12-ounce can of a cola soft drink has 30 to 50 milligrams of caffeine. Over-the-counter stimulants like NoDoz and Vivarin contain around 100 to 200 milligrams of caffeine per tablet. So for adults, the toxic dose would actually be equivalent to more than 10 cups of coffee or 5 to 10 tablets of an over-the-counter stimulant. Some other over-the-counter drugs that can contain smaller amounts of caffeine, it's usually around 32 to 65 milligrams per tablet, include some of the Anacin products, some Excedrin formulations, and also Midol. There are also many dietary supplements that are sold in stores that contain caffeine, and they also usually have herbal stimulants in them in various concentrations. They're usually promoted for weight loss and also to athletes to enhance their athletic performance. Now, what we're seeing a lot of are youth and adults drinking energy drinks. These energy drinks usually contain caffeine, and they're increasing in popularity, especially among the youth. Some of the better-known energy drinks are called Red Bull, 5-Hour Energy Shots, Full Throttle, Monster, Rockstar, Amp, and Redline. But there are many, many more that are on the market. These energy drinks often contain the same amount of caffeine as what's in a cup of coffee, but some of them have pretty large amounts. Some are actually concentrated liquids that are added in small amounts to another beverage, with as little as a teaspoonful of those concentrated liquids containing more than 100 milligrams of caffeine. One particular product actually contains 1,800 milligrams of caffeine in a 4-ounce bottle. That's equivalent to 22 and a half cans of Red Bull, just in that one small 4-ounce bottle. So misunderstanding the directions of these products has led to ingestions of toxic amounts. And several months ago, a mother of a teen called our poison center because her son wasn't feeling well after drinking about 3 mouthfuls of a concentrated energy drink. He didn't read the label. He didn't realize that the maximum daily dose was 1 teaspoonful. So we calculated that he swallowed about 9 teaspoonfuls, or the equivalent of 1,125 milligrams of caffeine. Fortunately, he did fine. He had a lot of nausea, vomiting. He had some tachycardia, hypertension, but he ultimately did okay after some observation in the emergency department. These drinks, these energy drinks, sometimes also contain a combination of herbal stimulants and supplements, such as taurine, guarana, which is another name for a natural form of caffeine, and also ginseng. Many of these energy drinks actually don't list the amounts of the ingredients or even the amount of caffeine on the label, so it's really difficult to know exactly how much it contains. Sometimes the energy drinks are used along with other stimulants to keep the person awake or to help them study, and that just increases the chance of them developing toxic effects. A dangerous practice that youth are engaging in now is mixing energy drinks with alcohol. Using stimulants can mask the effects of alcohol, and that increases the possibility of consuming excessive amounts of alcoholic beverages. Some products are being marketed that actually contain caffeine pre-mixed with alcohol, and they're sold in liquor stores and in bars. There was a study done in 2008 of college-age adults that were leaving bars, and the study actually showed why this is a really dangerous practice. Patrons who consumed energy drinks mixed with alcohol had 3 times the risk of leaving a bar highly intoxicated and were 4 times more likely to intend to drive after drinking than the other bar patrons who drank alcohol only. Also, there have been many cases of severe alcohol intoxication after drinking these combinations. One college in New Jersey just recently banned these beverages after 24 of its students were hospitalized for alcohol toxicity after drinking the alcohol energy drink mixtures. In response to some public pressure, a few of the beverage companies have withdrawn their products that contain alcohol and stimulant mixtures like caffeine. So if confronted with a patient who you suspect has caffeine toxicity, it's really important to call the Regional Poison Center at 1-800-222-1222 for help in diagnosing the patient and also in knowing how to manage the patient and figuring out what would be the toxic dose and whether the patient does need any care in the emergency department.
And it really is important to use your investigative skills in that situation because you need to look around and identify the cans of beverages or ask the question, what specifically were you drinking, since different labeled brands are going to have different amounts of caffeine.
That's exactly right. And again, we are seeing more of a problem with the alcohol intoxication. And you don't want to just look for the alcohol toxic effects, but also the caffeine toxic effects. So they, besides being intoxicated with the alcohol, they may have the tachycardia and the hypertension and maybe even seizures if they've really overdone it with the caffeine. And again, on a lot of these products, like you mentioned, they don't have the amounts listed on there, and so it's difficult to figure out if they have swallowed a toxic amount.
And the caffeine doesn't work as an antidote to alcohol, so you just end up with a wide awake drunk.
Exactly. That's exactly right. They're just more likely to drink more because they are awake and able to do so.
Well, Lisa, thanks a lot for this great information. This is a question I get quite a bit about the caffeine drinks and the energy drinks, so I know that my listeners are going to be very excited and interested to hear about this.
Well, good. And again, if they do have any questions, please call the Poison Center and they'd be happy to help them out.
Thanks a lot. I do want to thank Lisa again for coming on and sharing her knowledge with us here for, two and a half years now here on the MedicCast. And it's great to have that resource for us. And those of you out there that have poison centers in your area, they provide a valuable tool and resource for you to learn a whole lot about what's currently going on in your region. So check in with your local poison center. And I do want to thank Lisa for coming on. Don't forget, you can head over to mdpoison.com for the Maryland Poison Center site. You don't have to be from Maryland to check out the website or even to sign up for their email newsletter. And Lisa sends out periodically toxicology updates, little one-page tidbits that you can hang in your station, and it's easy to review, and it just covers a basic type of one-page item on a specific type of toxicology emergency or an overdose, or sometimes trends that they're seeing with certain types of drug use in the calls that they receive to their poison centers. And that's going to wrap up this week's episode of the MedicCast. I do want to thank everybody for checking out the show this week and remind you to head over to mediccast.com/blog and check out all of the links in the show notes for this and every other episode that you need to. You'll find a link for show notes right at the top of the page. Click that link and then follow up on the episode. You'll find the most recent episode listed first, and you can go ahead and scroll down and find the show you're looking for. You'll find links to the news items, additional resource links for the tip of the week, interview segment like we had with Lisa. There's information on caffeine and further things you can follow up on. Remember, we can cover brief overviews here on the show, but it's your job to use the additional information, your own protocols, your own instructional guidelines, and use that to figure out how what we talk about here on the show fits into your scope of practice. If you'd like to get back in touch with me, you can do so by sending me an email to podmedic@mac.com. You can also call in on the voicemail line, 941-306-3342. And don't forget, you can also become a fan of me and the show over on Facebook. The MedicCast has a fan page at facebook.com/MedicCast. And you can also find me on Twitter and Facebook under my handle, PodMedic. That's it for me. We're going to go ahead and close out the show like we always do with some pretty cool PodSafe music. And this week's episode is no different. We've got The Last of the American Superheroes by American Heartbreak. If you like what you see and listen to in the show notes, check out their link and go ahead and let them know you heard it here on the MedicCast. I'm Jamie Davis, the Pod Medic. I'll be back again soon, every week, with another episode of the MedicCast. And in the meantime, please remember, scene safety and BSI.
We've seen them on TV our whole life. Super Friends were the Rolling Stones, were larger than life. I can be like anyone I see on a record